Welcome to the conference session titled Understanding MDS Risk Scores. Thank you for joining us. My name is Alice Hauk, Senior Director of Health Professional Programs, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help us manage the incoming questions. First, submit your entire question all at the same time. And second, please do not share private health information in your question. Our speakers cannot answer any specific questions related to your healthcare. In the beginning of the session, we will open the audience poll feature in the right-hand engagement panel. Please click on the icon in the panel to navigate between each as you watch the session. The poll will remain open for the first 5 minutes of the session. Today's specialist is Dr. Swapna Thoda. Dr. Thoda is a board-certified internal medicine physician in Regional One Health's Medical Oncology Division. Currently, Dr. Thoda is an assistant professor of oncology at University of Tennessee Health Science Center. She previously served as an assistant professor in oncology at Roswell Park Center and University of Buffalo Jacobs School of Medicine and Biomedical Science. With that said, welcome, Dr. Thoda.
Good afternoon, everyone. Thanks, Alice, for that kind introduction. It is my great pleasure to be with you all this afternoon. I'm here in Memphis. It's a rainy day today, which cools down the temperatures here. So it's a lovely day to be with you all virtually. I hope you're all doing great. There's nothing more gratifying than to be with a group of patients that want to be well informed about their medical conditions. So it's an honor to be talking with you all, to give you an understanding of what MDS is and how do doctors decide on communicating prognosis to their patients. What are the tools we have to risk stratify a patient that we see with the diagnosis of myelodysplastic syndrome. With that, I'll give you a brief background about today's agenda for this presentation so that we're all on the same terms. I do talk some basic words about how MDS presents, what does it mean, how it's affecting each patient, the history of classification of myelodysplastic syndromes, and the tools that we commonly apply to prognosticate our patients, meaning how do we predict their disease is going to behave, how aggressive or less aggressive it is, and what are the most recent updates we have using the science and advanced technology that is currently available to the doctors. How are we able to improvise our current prognosticating systems to better communicate and educate our patients? And how does this prognosis conversation or the tools that we have really tie into your treatment? And how do we decide using these tools? And is it really related? These are some of the topics we will be talking about today, and I will take questions at the end of my presentation. Myelodysplastic syndromes. Syndromes is really a group of disorders put together because there is a common feature. Myelodysplasia, myeloid being bone marrow, dysplasia being abnormal, is how all of these disorders are put together. So all the patients are characterized together with an abnormal bone marrow that produces abnormal blood cells. So it's a heterogeneous group of patients that have a common diagnosis of MDS. Because of this heterogeneity, when you come across a peer that has the same diagnosis, their story could be entirely different from your story. How do we unify these patients, yet divide them into cohorts of how different groups of patients behave differently. That's where the prognosis classification comes into play. Myelodysplastic syndrome, although one of the common myeloid disorders, is a rather rare disease. It only occurs in about 4 cases for every 100,000 population that we see. And there is an age dependency for this incidence. As the age increases of the population, there is an increasing in incidence of myelodysplastic syndromes. If we take a group of 100,000 patients who have an average age about 16 years, the incidence, instead of being 4 cases, increases into double digits, and we come across about 20 to 30 cases per every 100,000 patients. Normally, there is a gender predisposition for men to be more affected with myelodysplastic syndromes. The cause of this is unknown, but it is in the odds of 1.5:1. So for every woman diagnosed, there will be 1 or 2 more men who would have a diagnosis of myelodysplastic syndrome. One of the common things in my very first visit that I get asked by patients who are understanding this diagnosis as to they were healthy all this time, how come this happened to them? It is really difficult question to be posed to a physician, and we don't have perfect answers, but over time of understanding the natural associations of myelodysplastic syndrome and the risk factors, the common themes that have arisen is it's common in elderly patients. So, aging is commonly associated with myelodysplastic syndromes. A subset of patients have exposure to prior chemotherapy or radiation therapy for any other malignancy they have seen in life. It could be breast cancer, it could be skin cancer, any kind of tumor that they had to undergo radiation or chemotherapy. These patients are at a long term at risk for myelodysplastic syndrome from the toxicity of these agents. Smoking is frequently associated or at increased risk for myelodysplastic syndrome. Although it is unusual for myelodysplastic syndrome to be running in families, there is a rare group of patients where multiple family members are affected with similar diagnosis. There's specific way of identifying these genes that predispose these families. This particular scenario is called germline predisposition. World Health Organization has identified this risk category as to be a distinct category and has put it in a separate classification. More recently, with the availability of sequencing and many patients receiving genetics counseling and genetic studies, people have identified mutations or DNA changes in their blood. And this condition, without any abnormalities in their blood work or no low blood counts, this particular condition is called clonal hematopoiesis. It is now established that patients with clonal hematopoiesis over time have a higher risk of developing blood cancers, one of which includes myelodysplastic syndromes. So to specific patients, I can't tell them how they develop myelodysplastic syndromes, but these are the risk factors, or if somebody has a question as to how can they risk mitigate themselves from not getting this condition, avoiding smoking, lifestyle modifications are some of those things that we can advise these these patients who are asking these questions are some of the strategies to they can apply. Myelodysplastic syndrome is a morphological diagnosis. What do I mean by that? So most patients that present with these condition present with low blood counts, and the low blood counts are arising from a bone marrow. Bone marrow is where all the stem cells, the mother cell, sits and makes healthy red blood cells in all of us. In myelodysplastic syndrome patients, bone marrow has abnormalities. So when you undergo a bone marrow biopsy and aspiration and look at the cells under microscope, if there is presence of dysplasia in greater than 10, meaning abnormal cells, if it is present in greater than 10% of the cells that have been identified as being abnormal, that establishes a diagnosis of myelodysplasia or brings that into question. The other things besides dysplasia being present in your bone marrow biopsy is really the presence, the degree of your Cytopenia. Cytopenia means low blood counts. So if you're anemic, your hemoglobin is less than 11 grams per deciliter. Neutrophils, which are a type of white blood cells that help us fight infections, if it is less than 1500 per microliter, or platelets that help us to form clots if they are less than 100,000. These are the patients that you have to ensure you look at all different causes as to why they develop the low blood count. So is extremely important to make sure there is no nutritional deficiency that has been identified that can help explain the low blood counts, or an infection, unusual mineral deficiencies such as copper, heavy use of alcohol in their past, or people could have immune disorders and could be taking immunosuppressive therapies or have had recent chemotherapy exposure that can make your blood counts look abnormal. All of these conditions have to be accounted to when you first meet your doctor and go over your diagnosis. It is extremely important. This is the very first step, first service I provide most of my patients that I see to ensure that dysplasia, the abnormality we see in the bone marrow, is not from a nutritional deficiency, is not from an infection, but truly is arising from an abnormal stem cell, a blood cancer that's giving rise to low blood counts. Besides dysplasia, there are other features we look in the bone marrow biopsy, one of which includes increased immature cells. We call them blasts. If they are increased over 5%, we call that excess blast, and this is one of the features of myelodysplastic syndrome. Chromosomal abnormalities or DNA changes. DNA is the signature that we all carry, code that tells our cells how to work. If any abnormalities or clonality is discovered in our chromosomes, our DNA, by any of the testing methods that we have available, which includes methods such as karyotyping or cytogenetics, FISH analysis, or sequencing methods. These are all the different lab techniques we use to establish clonality. So presence of all these three features, low blood counts, presence of dysplasia in your bone marrow, excess blasts, and chromosomal abnormalities put together give you a diagnosis of myelodysplastic syndrome. Once you have been diagnosed with myelodysplastic syndrome, I have mentioned everybody's story is different. This picture really illustrates how different MDS impacts everyone's life. There are some common features as to how these patients come into our clinic. It could be they had an infection because of low neutrophil count or low immune cells. It could be they have easy bruising, or they're totally asymptomatic, went to a routine doctor visit, and identified to have low blood counts. Tiredness, fatigue is a big thing in a lot of patients. So each patient can range from being asymptomatic all the way to having had a complication. So if you take to 100 patients that have this diagnosis, this picture really illustrates what happens to them over lifetime. Some patients have a higher risk myelodysplastic syndrome and will need a stem cell transplantation as a curative therapy to get rid of myelodysplastic syndrome, and their natural history is representative of outcomes that come with transplant. In some patients, they are suffering the consequences of having low blood platelets and will have issues with bleeding and bruising. Some are transfusion dependent and have iron overload. Some might have frequent infection troubles from not having a good immune system. A majority of them are asymptomatic, they're elderly, and really it's a chronic illness in them despite being called a blood cancer, and really suffer from geriatric conditions. A subset of them progress to a more aggressive form of blood cancer called acute myeloid leukemia and receive treatment that's required for treating acute myeloid leukemia. So really everybody's story, like I mentioned in the beginning, is very different from each other. And that is why it is very important upfront when you get diagnosed with this condition to talk to your doctor about what does this mean to me? How can you tell how this impacts me. Some of the things we look into when the patient first comes is to what kind of MDS do we have? WHO, World Health Organization, has given a few iterations of classifying myelodysplastic syndrome into some morphological categories. There are six specific categories, and they used to be heavily rely on how your bone marrow look. Is there single lineage dysplasia called MDS with single SLD, single lineage dysplasia? Is there dysplasia in all three cell lines called refractory cytopenias with multilineage dysplasia, or more recently, MDS with multilineage dysplasia? Are there ring sideroblasts? Is there specific chromosomal abnormalities such as deletion 5q, or are there excess blasts? Some of these categories have been retained in the most recent iteration, but there has been increased emphasis on biology. I can share example of some of the subcategories and how the most recent classification has impacted the definition of such diagnosis. Patients who have been diagnosed with refractory cytopenias with unilineage dysplasia, if they are identified to have ring sideroblasts, but at a lower burden, but at the same time have a genetic change in a gene called SF3B1, they are now reclassified into MDS with ring sideroblasts because of the association that has been discovered between SF3B1 mutation and presence of ring sideroblasts. So the previous threshold of having to have 15% ring sideroblasts has been lowered for these patients grade to less than, even if they have less burden, which is 5% or above, and have a concomitant mutation, they can, with the new classification, morphological classification by WHO, reclassified as MDS with ring sideroblasts. Similarly, patients with isolated deletion 5q were placed in this category of MDS with deletion 5q, but it has been increasingly recognized that even with presence of one more chromosomal abnormality, the patients of these characteristics can still be safely classified under this MDS with deletion 5q, which tends to have a better prognosis. So we are improvising our morphological classifications. This is one of the key features I look for in my bone marrow, what specific type of MDS of the six subtypes that we have. There are other categories that are present in WHO distinct from these six specific categories, including MDS that happens in children, referred to as RCC, and families that are predisposed to developing myeloid neoplasia or MDS. This is a separate WHO category, and people who developed MDS as a consequence of their previous exposure to chemotherapy or radiation therapy. So with all these things in the background, and we use all the details, their blood counts, how the patient is presenting to us, and all the details of the bone marrow biopsy. The next biggest question, once we have confirmed the diagnosis, made sure the dysplasia isn't from any other reversible causes, establishing the diagnosis, subclassifying in the bone marrow biopsy, working with your pathologist as which specific type of MDS you have. The second thing, the biggest thing the patients have is, so what does this mean for me? Tell me how this impacts my life. They're asking us some questions to predict and prognosticate the specific type of MDS that they have. Doctors frequently address these questions using tools we have to us, one of which is just looking at my patient, how old they are, how active they have been in their life, what are their medical illnesses, comorbidities they have. Besides this, the details of the bone marrow biopsy and their blood counts are the other factors. Putting all of these factors together, both the patient-specific factors and disease-related factors, several prognostics tools have been used to discuss this concept of, well, how does this diagnosis impact my life? How long do I have to live? All these questions. Well, some of the most frequently used prognostic scoring systems are called International Prognostic Scoring System, which I will refer to as IPSS in the rest of the presentation, or most recently, it has been improvised to what's called Revised International Prognostic Scoring System, or IPSSR. There are other systems that are available that are used in parts of our country and across the world called WPSS, or WHO Classification Based Prognostic Scoring System, MD Anderson Global Prognostic Scoring System. And there has been an effort to improvise even on IPSSR, something called molecular IPSS, but this is a work in progress. So let's review in the next few slides what is IPSS and what is IPSSR, what factors are included in it, and why it needed revision from IPSS to IPSSR. So here is a IPSS scoring system. This is a historical classification system. It was published in 1997, taking 800 patients from different academic centers and looking at all the clinical features, their classification, blood counts, blasts, chromosomal abnormalities, and statistically modeling which patients do better and those patients that do not do better. This system predicts for survival. How long do these patients live with this diagnosis? And it predicts for the risk for transforming to more aggressive blood cancer, which is acute myeloid leukemia. Patients are categorized in IPSS into 4 subcategories, including low, intermediate 1, intermediate 2, and high risk. While for low risk patients, MDS looks like a chronic illness with a median survival that's ranging in multiple years. For patients with high risk MDS by IPSS, the median survival is measured on an average less than a year, so measured in months. So it clearly classifies patients with high risk disease and low risk disease based on the following factors. The most important factors that are accounted for in IPSS include your bone marrow blast percentage and are categorized into 4 subsets: less than 5%, 5 to 10%, 10 to 19%, and greater than 20%. What are the chromosomal abnormalities look like? Are they good, intermediate, and poor? Are the 3 subcategories? And I have highlighted them on the slide. And how many cell lines are affected? Is there only anemia or anemia and thrombocytopenia? So number of cell lines, all of these factors put together gives you a scoring system that can range anywhere from 0 to 3.5. And based on your score, you're categorized into the 4 categories that I have mentioned earlier. IPSS was published or the work has been done in 1997, before the advent of all the hypomethylating agents and the novel treatments that we have, that we frequently treat our patients using those agents. The historical nature of this cohort does not necessarily apply, and the definition to which all the factors have been studied in this cohort don't completely reflect the heterogeneity that we see. To account for all these factors, the newer treatments, which led to improvement in survival using hypomethylating agents. So IPSSR really applies for patients that are seeing more recent treatments and has an improved precision to how we account for low blood counts. Is somebody with the hemoglobin of 10 grams per deciliter different than somebody with 5 grams per deciliter? How does your platelet count that you're presenting with impact your longevity that you have at this diagnosis? So in IPSSR, 5 characteristics are accounted for, including the same cytogenetic abnormalities, but this time instead of 3 subcategories, they're put in 5 subcategories of very good, good, intermediate, poor, and very poor. Similarly, blast percentage is classified into 4 subcategories, which is different than IPSS, the thresholds that are applied. And cytopenias have an improved precision in this classification system. As you see in this slide, it clearly subclassifies patients into 5 subcategories, including very low, low, which are more like chronic illnesses with multiple years in their life, with very low patients reaching median survival, reaching close to a decade. intermediate patients, and very high. This model also predicts for overall survival from your time of diagnosis or presentation. And it also predicts for transformation, risk of transformation to more aggressive blood cancers. So each specific category that you have been assigned to speaks for a certain risk percentage of transforming to AML or not. So this particular model has been applied for close to almost 10 times the number of IPSs. So it's a validated study and mostly utilized study by majority of clinician, despite the multiple variables that are included, because it represents the more inclusion of more modern therapies, and the improved precision really classifies patients in an improvised manner. This new risk stratification that we currently use, IPSS-R, also takes into account the age of the patient. In the slide here, if you take a patient that has, for example, an IPSS-R risk category of 2, if your score is 2, and your age less than 60, for example, it is 80% likely that you fall into the category of very low risk IPSSR category. But if you're age above 60, then you have a high chance of being into, instead of being on very low, likely to be classified on low. So how age and performance status impacts your MDS and prognosis overall. So it accounts for biological factors that IPSS did not account for. There is slight discordance between classification. A patient who was previously classified as intermediate risk by IPSS previously has been either classified into very low or high risk. Because of the improved precision, now these patients can be reclassified into an improved categorization of MDS prognostic model. Here is yet another example. In the cohort of IPSS, the 800 patients that were studied, about a third of the patients were put in low risk category. In IPSSR, if you combine very low and low together, which are more chronic illnesses with a good prognosis, about 50% of the patients, because of improved precision, are now being able to reclassify it as very low. So you see the discrepancy between IPSS and IPSSR, although subtle and both are still clinically applicable. IPSSR has a capacity to have an improved precision in restratifying or being more predictive in the current age. I've highlighted here the differences between International Prognostic Scoring System and the revised one. While in IPSS, we have 4 categories. In IPSSR, we have 5 different groups that have distinct prognostic median survival and risk of transforming to acute myeloid leukemia. Your score can range from anywhere from 0 to 3.5, and that goes with the subcategorization. In IPSSR, because of the precision that's given to cytopenias and the different classification of cytogenetics, your score can range anywhere from 0 to 10. Cytogenetics were previously only classified into 3 subgroups. In IPSSR, because of improved knowledge and increased strength and advancement in science, cytogenetics are now classified into 5 subgroups. Blast percent threshold in IPSSR, anybody over 10%, there is no further subclassification, which is different from IPSS. Let's apply this to some of the frequent clinical scenarios that we see in clinic. Let's take a 64-year-old otherwise healthy person presenting to a physician because of fatigue and was noticed to have low blood counts. The first thing we need to know is the blood counts. So hemoglobin was 10.5, neutrophils were 0.6 per microliter, and platelets 77. A bone marrow biopsy was done, percentage of blasts and karyotype was identified. And when you plug in all this information, your IPSS risk category has been classified into intermediate 1, while IPSSR has been classified into 3.5. In this particular scenario, both IPSS and IPSSR are concordant. Let's imagine another patient, 68-year-old man, similar blood counts, but to a lower level. So presenting with lower blood counts, hemoglobin instead of being 10 is now 8, platelets instead of being 77 now has been 30,000. Bone marrow blasts and cytogenetics look similar. This person, when you apply IPSS and IPSSR risk categorization, IPSS comes back as intermediate 1. Previously, we would have a similar conversation for the 60-year-old gentleman, similar to the previous gentleman that we have. But IPSSR reclassifies these patients because of the emphasis it gives on to what degree you're anemic, to what degree you're thrombocytopenic or having low platelets, and reclassifies these patients into a higher categorization as high risk because their score was 5.5. Let's look at one more example. 84-year-old gentleman presenting with easy bruising is noticed to have low blood counts, underwent bone marrow biopsy, similar blast percentage. So for all purposes, this patient looks the same as the previous 64-year-old gentleman for blood counts. But in their bone marrow biopsy, although they have the similar blast percentage, cytogenetics shows changes in 7th chromosome, an isochromosome for 17p, and multiple chromosomes that are abnormal. This gives them a complex karyotype that recategorizes the cytogenetics risk to a very high risk category. Putting all of this information, even though this patient is presenting as same blood counts as the previous patient, you have now realized that the impact of cytogenetics or chromosomal abnormalities has on the disease biology and the natural history. This patient is classified, if you plug in all the information, as intermediate 2 risk by IPSS, or with a score of 6, classified as IPSS are high risk because of these cytogenetic abnormalities. So slight discordance in how cytogenetics have been reclassified more recently in IPSSR, and IPSSR being more reflective of the biology of this MDS diagnosis. One final example, just to continue to emphasize on the degree of cytopenia, same patient, few months later, if you imagine that the blood counts went up and the blast percentage, you see there is a dynamic shift in IPSSR risk category and in IPSS risk category. So as you go through the disease, if you're, depending on the stage you present, imagine this patient waited a few months to come to a doctor and has much more advanced disease and higher blast percentage, your IPSS risk categorization is reflective of that presentation and speaks for the biology of the disease and where you're currently at with your diagnosis. So more recently, these are all the tools that we currently apply when my patient asks me, what does this mean for me? So I go through the algorithm with my patient, explain each category, and give them their score and tell where they fall in. Some of the more recent lab techniques that we have been increasingly adapting in clinic are application of next generation sequencing. What has been identified more recently is that patients with MDS carry, besides chromosomal abnormalities, mutations, point mutations in specific set of genes that are frequently found to be abnormal in MDS. To mention a few, these are genes like TET2, SF3B1, TP53, and so on and so forth. How do we really apply these mutations in day-to-day practice? Some of them have targeted treatments in a relapse refractory. Besides giving us more insight into the biology, how these genes play a role in developing myelodysplastic syndromes, can they really be used to predict or improve our prediction of how a patient's diagnosis impacts their life or what their prognosis might look like? There has been studies that combine sets of genes and identify what each individual gene or combination of genes would impact their prognosis. One of the study previously published by Dr. Behar and group showed that mutations in TP53 EZH2, ETV6, A6L1, and RUNX1 carry a poor prognosis. So when you take a group of low risk patients and reclassify them based on presence or absence of this mutation, you notice that they can be recategorized. If they do have this any of these mutations, they are now categorized into intermediate risk as opposed to low risk that they were. So application of mutations can reclassify patients or can predict for biology in a more precise manner on top of IPSS risk or IPSSR risk categorization. There has not been a standardized molecular model that applies all genes that we have currently discovered in myelodysplastic syndrome, but there is an effort to unify data across many countries and a group that working diligently to develop the molecular revised IPSS that is to be published in future, but it's currently a work in progress. If you take SF3B1 mutation, it is one of those mutations that has a good impact on your diagnosis. Patients with SF3B1 mutation have a longer survival compared to those patients that do not have that mutation. So when you take patients that were previously categorized into low or intermediate risk MDSs, this study by Dr. Malcovati and group from Italy have shown that presence of SF3B1 mutation has an improved prediction on top of IPSS, and these patients have an improved survival compared to those patients that do not have SF3B1. Similarly, number of mutations that you have at the time of diagnosis also impacts, has an association with your morphological classification. Patients that tend to fall into low risk IPSS category tend to frequently have less number of mutations. If you take for patients that have 4 or more mutations, the percentage of patients that have low risk type of MDS that have multiple mutations is lower, as opposed to if you move on to excess blast phase and look at the number of patients that have multiple mutations, it can be noted that a number of patients that have a more advanced form of MDS have more mutations in their genetic makeup of their bone marrow. So that is to impress on the fact that at a case-by-case basis, we do apply molecular data to come up with or predict their prognosis. And these are frequently happening in tumor boards or identifying treatments in them. So how does all these predictive models or prognostic models really tie into treatment when you get diagnosed and when you are symptomatic? Although observation is part of the treatment for some patients, majority of patients do end up needing treatment. How does this IPSS risk or really predict for any response to treatment? So let's go over those details. The treatment goals is really depending on your risk category. So if you have a more chronic illness, if you fall into low or intermediate type of MDS, the conversation that your patient, and depending on your age, there is an age dependent factor here too. Your physician talks to you about, here is where we are and what are our goals. Our goals are to make sure that we enhance your bone marrow function so you remain transfusion independent and you are able to enjoy an improved quality of life. So let's focus on improving blood counts. For a young patient, even if you are in low risk MDS category, someone in 30s or 40s or 50s, prognosis of only another decade does not sound very exciting. So in case by case basis, if there is a younger patient with myelodysplasia as their diagnosis, we do consider curative intent treatments, which includes bone marrow transplantation. So IPSS risk category really signifies to the patient and to the physician, where are we going with this diagnosis? So we use that classification system to establish goals of treatment with the patient. The agents that are commonly used in this subcategory are erythropoietin injections, lenalidomide, luspatercept, or immunosuppressive drugs, hypomethylating agents. Are there prediction models? Does IPSSR predict for response to these agents? IPSSR does not, although it establishes your goals of care, does not predict for response to these agents. There are certain other predictive models for response assessment. For example, if you take EPO injections or erythropoietin injections, it is known that if you have a baseline erythropoietin that's less than 200, although they are still applied for levels less than 500, because EPO levels fluctuate. If you have an EPO level that's less than 200, and your transfusion burden is not high, meaning less than 2 transfusions per month, then you're likely to respond to erythropoietic agents. It is a well-established fact that deletion 5q patients are exquisitely sensitive to lenalidomide. Similarly, morphological classification in MDS with the ring sideroblasts predicts for response to luspatercept. This is not to say that those patients without ring sideroblasts do not respond, but this is a biological marker that predicts for response to these categories. So the response prediction model in low and intermediate risk does not predict for response to treatment, only sets up the goals for your treatment. Let's look at the high-risk patients. Treatment for high-risk MDS patients are slightly different because they have a more advanced phase of MDS. There is an emphasis in decreasing the blast percentage to restore hematopoiesis or normal hematopoiesis for your bone marrow to be able to make healthy blood cells. So there is emphasis in blast reduction. There's emphasis in improving overall survival because without treatment, majority of these patients, especially classified into very high and high risk, quickly transform to AML. And to continue to maintain their quality of life by giving these treatments. And when applicable, transplant is highly considered in patients that are eligible because of their poor prognosis that comes with high-risk MDS diagnosis. The agents that are commonly applied here are hypomethylating agents. Although they are the most commonly applied treatment for patients with myelodysplastic syndromes, there are few predictive factors that predicts for response to these treatments. There are studies that have shown presence of a mutation of TET2 has been predictive of MDS. This has not been consolidated by other studies, or lack of a complex karyotype sometimes predicts for these, or not having previously received, so a low-grade MDS that has transformed to a more advanced MDS. No prior therapies has been one of the factors that has been published to be predictive of response to hypomethylating agents. But none of these factors have been replicated serially among many cohorts of patients. And that's why I left question mark in the slide there to say, these are some of the factors that are thought to predict for hypomethylating response, but really there is no predictive model. We do not know as we stand today who responds and does not respond to hypomethylating agent. One of the serious troubles when we treat MDS patients is when hypomethylating agents have worked in the past and have stopped working, or a patient has never responded to hypomethylating agent, a state what we call HMA failure. Really the biggest impact from here, the biggest prognostic model or predictive factor as to how a patient do from here is dependent on patient biology. How strong are they to withstand stronger therapies such as induction treatment and their ability to follow it up with the transplantation. So HMA failure is a tough clinical scenario to manage. And the most biggest predictive model there is their ability to withstand induction chemotherapy and transplantation. In this space, there are several investigational agents that are currently in clinical trials, including BCL2 inhibitor venetoclax, targeted therapies such as IDH inhibitors. So some of the mutations that have been identified in your initial diagnosis, such as IDH1 or 2, can make you a candidate for if you ever were to receive other therapies and run out of treatments and are being considered for clinical trials. These are some of the therapies that could predict for response presence of an IDH1 and 2 mutations. There are other immunotherapeutic approaches that are being entertained in the space of myelodysplastic syndromes, including the TIM3 targeted and CD70 directed therapies. What predicts what percentage of expression of CD70? These are all the things we are yet to learn. So a lot more to come in terms of predictive model and prognostic models in the sense of applying molecular data and how we really tie into treatments for them. Mutations are predictive of your outcomes if you were to undergo bone marrow transplantations. What kind of mutations do you carry and how your outcome is going to be following your transplantation. It is now being replicated and shown consistently both in acute myeloid leukemia as well as in myelodysplastic syndromes that if you have a TP53 mutant myelodysplasia, it predicts for poor outcomes even with transplantations. This particular publication also talks about your age, TP53 mutation, and also presence or absence of some other mutations that belong to JAK2 or RAS pathway. So if you're younger patients that do not have any of this high risk category mutations or other odd clinical features, your overall survival post transplantation is really good as compared to an older patient that has these mutations in RAS pathway or JAK2 have a median survival of only 30% at 3-year follow-up following transplantations. So mutations can be used to predict how bone marrow transplant impacts could be on your life. In summary, IPSS categorizes patients into 4 prognostic groups with a distinct survival and prediction for risk for transformation to AML. IPSS is very user-friendly. It lacks precision in comparison to IPSSR and is not dynamic and is not applicable with the more recent therapies. IPSSR categorizes patients into 5 groups and can be applied at any phase of the disease. Prognostic models are including of molecular data will allow for increased precision. One has to be, it is a work in progress at the moment to come up with this model. IPSSR, while frequently used to design therapeutic trials, is not a biomarker for treatment response. With that, I would like to thank AAMDS Foundation to be giving a chance to invite me to be present with you all today. Thank you very much for your attention, and I really appreciate my institutions that I am affiliated with to allow me to continue to provide care for patients with aplastic anemia and MDS. I really enjoyed taking care of these patients. I'm very thankful for this opportunity. Alice, I can take questions from here.
Thank you, Dr. Thoda. We do have a question here. As your disease progresses, does your classification also change? For example, if low risk DEL5 in 2009, but now have multilineage dysplasia with TP53 and TET2, are they now a different classification or always the DEL5?
I frequently classify my patient at the first time I meet them. So if I'm meeting my deletion 5q patient, this now I categorize them based on the blood counts on that particular day. Years later, or had the patient never seen me during the deletion 5q but presented 10 years later with really low blood counts, excess blasts, and I'm meeting them for the first time. The first time I meet, I have all the information. That's the time I apply IPSS scoring system. IPSSR, like I mentioned, can be dynamically changed. So from the time of your diagnosis, you have a particular IPSS category, and it gives you, it predicts for the longevity or your risk for AML transformation. As you move through the disease process, it is that you, theoretically, you could think you're moving as your blasts increase and stuff, you could think you fall into a higher risk, and it is a natural progression. But most physicians apply IPSS and IPSSR not at every clinic visit. We don't talk about what's the longevity or risk of transformation. It is a conversation I have at the initial diagnosis. Every MDS patient, as you see in the curves, there is a decrease in the curve because they ultimately move on to higher risk groups, and either MDS is how they pass or other things happen to them. So even though they're categorized as low risk, this year, 10 years from now, it doesn't mean they're still low risk. They could have transformed to other stages of MDS. I hope that answers the question.
Thank you. And we have another question. Does SRSF2 have any predictive value?
So no consistent results, but most of the splice, it belongs to a group of mutations called spliceosomal mutations, with the exception of SF3B1. The other mutations have been associated with poor outcome. This is true to U2AF1 mutation and other splicing mutations. SRSF2 mutation is categorized into this. In some studies, it has been associated with a slightly adverse um, impact on your survival, but it is not as bad mutation as what we think of RAS pathway mutations or TP53 mutations. Also, the statement I just made has not been replicated in a bigger cohort. That's why I can't give you a confirmed answer, but it is thought to be either indeterminate or one of the adverse risk mutations. This is a mutation that has a bigger impact in another disease called chronic myelomonocytic leukemia or CMML. But in MDS category, its impact is at the moment considered as indeterminate.
Thank you. And as a closing question, for patients who may not know their risk score at this point, or either because their physician hasn't told them or they didn't know to ask that question, why do you think it is important that they know their risk score and what system was used to determine that score?
So that's a great question. I mean, one of the things, you get diagnosed with a blood cancer, you would want to plan all of the events or things like that. It would give you a sense of comfort or a sense of planning as to how to move on with life. It increases your level of conversation. It is always good to proceed with information, in my opinion, and talking about your prognosis or talking about your predictive models with your physician really allows you to have a more objective definition of what this means. It's not a subjective opinion. It's not about where you live or what happening or what is that. It's more about the disease and how it impacts you. If you do not want to know about this, there are a group of patients that want to know broadly what this means and if they need treatment. And does that mean they need to take time off work to answer any of the questions that are to come in your future? Or when would I need treatment? How long do you think, can I see my grandchildren? To answer any of these questions, the method that we fall back on is this prognostic scoring system. I really cannot see how a physician can help you in your day-to-day life, in planning events in your life, and in help improving your methods or providing comfort. If you have a very low risk SF3B1 mutant MDS, you get diagnosed, we see each other every 3 months, you should be okay most of the time, is a level of comfort I can only provide if you're able to know prognostic scoring and have a thorough workup. So it's a long answer for a short question. Thank you.
No, that's very helpful, and we get that question from patients as well. So thank you very much, and thank you, Dr. Thoda, for sharing your time and expertise with us today. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMDSIF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. Be sure to visit the exhibit hall in between sessions. The next educational session will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 37 years. This concludes the session.